So good afternoon, everyone. We will start the webinar now. So thank you, Joël, for organizing this webinar session. We had a really great session on Wednesday with the Francophone participants, so now this one in English. So the setup of the session will be that I will present a first part of the PowerPoint presentation, and then Zubin Shroff from the Alliance for Health Policy and System Research will continue with the PowerPoint, and then the session, then we will start the question and answers process, which will be facilitated by Joël and my colleague Valérie. And Joël will have to dispatch questions to Zubin and myself. So we have to end just before 4. So we hope that you will enjoy, that you will not have too many technological problems, and we expect some more participants to join. But now it's time to start. Okay, so this presentation is about a multi-country study, which was coordinated by the Alliance for Health Policy and System Research, together with the Institute of Tropical Medicine and with the assistance of the financial assistance of the Norwegian aid agency NORAD, and with guidance from WHO Geneva. So the presentation will be in two parts that I just mentioned. I will say a few words about the multi-country research, and then I will give you two main messages. That scaling up is a multidimensional, and scaling up is a 4-phase process. And then we will go to the presentation, the slides by Zubin, who will analyze how we move from one phase to the other, and use a framework to document the barriers and enablers. And then Zubin will share also some other lessons from the cross-country research. So this is the main question of the project, of this multi-country research project, was what are the enablers and barriers for the scale-up of RDF schemes? So it was a health policy analysis. It was carried out, as I mentioned, in 11 countries. So these countries were selected on the basis of the applications sent by country research teams. So it's not so much a selection of countries, but much more selection of country research teams. And so there, among the 11, there were 8 African countries and 3 non-African countries, Armenia and Macedonia for Europe and Cambodia for Asia. So from these 11 countries, 10 countries submitted a final research report, and our findings are mainly based on these 10 countries. So as I just mentioned, this was not an impact evaluation, it was not quantitative research, it was really qualitative research, and it was about documenting the policy process of scale-up of results-based financing schemes, mainly performance-based financing schemes at country level. So it was an iterative process. The first stage for the research was to do, each country team did some documentary review, and from there they developed a timeline which reports, the timeline reports really the story of the development of the PBF RDF scheme in the country. And then there, at that stage, we had the ethical approval, and so we were able in each country to interview key informants. These key informants provided a lot of insight and information, which allowed the country team to update the timelines, but which the informants also provided more reference, more documents, and these documents again allow us to produce a very thick timeline and a very good description of the scale-up. So this timeline was helpful really to organize the thinking and to be able to construct the story. So now I will focus on two main ideas, I think, which are maybe the ideas we really want to share with the PBF community. And so the first idea is that scale-up occurs over 5 dimensions. So usually people understand scale-up of an intervention, a program or a scheme, as mainly as an issue of expanding the coverage of the population. So you expand in a geographical way, you cover more districts, more provinces, and this is how scale-up is usually understood. And this is of course very important, but we will see that scale-up is much more than that. So we propose a view which says that scale-up occurs on 5 dimensions. So there is the first dimension of population coverage, and there indeed you get the geographical coverage, but you can imagine also a scheme expanding in terms of age and income groups. So for instance, you could have a RBF scheme focusing on children under 5, and then at some stage you could decide to expand the scheme also to adults or teenagers and so on. You can also have a scheme focusing on the socioeconomic groups, for instance, the poorest, like Health Equity Fund, and then you could decide to increase the coverage to other socioeconomic groups. So obviously, population coverage, you can count it in terms of people covered. That's the first dimension. So the second dimension would be service coverage. It's about the recognition that when you scale up, you will increase the number of facilities. This is the way you do it actually to increase the population coverage. But you can expand also in terms of types of facilities. You may start, for instance, a performance-based financing scheme focusing on health centers, and then you decide to expand it to district hospitals as well. So you can also have an expansion in terms of affiliation of services. For instance, first you start with public facilities, and then you expand to private for-profit facilities. And then you can have also expansion in terms of types of services, where you start, for instance, focusing your RBF schemes on HIV/AIDS services, and then you expand to reproductive health, maternal health, child health, and so on. So there are all these kind of possibilities in terms of scaling up on the service coverage dimension. The third dimension, well, maybe the term scale up is not the most appropriate, but it's definitely a dimension of expansion for your scheme as well, is when you try to integrate your scheme better with the health system. So there, the easiest is to think of the 6 building block frameworks. So you have governance, finance, human resources, information, drugs and equipment, and service delivery. And with each of these blocks, it's possible to have a better integration of your scheme. We will come back on that. The fourth dimension of expansion of your scheme is when you diffuse your principles, your concepts, your solutions to other sectors. Okay, so we have seen in a few countries situations where the PBF started in the health sector and then moved as well to the education sector. That's another kind of expansion, that's another kind of scale-up. And then the fifth and last dimension for measuring your expansion would be knowledge and ideas. Okay, this is a situation where you start maybe with very limited knowledge, just with some theoretical idea, and then later you have an experience, you have a proof of concept. So then you have deepened your knowledge. Or you start with 1 or 2 experts, and in the end you have 100 experts. That's another kind of expansion of your knowledge. Or you start first with an intuition, a hypothesis, and later you have rigorous evidence documenting the intervention. That's another kind of expansion of knowledge. So these are the proposition we make to all of you, is that when you think your scale-up, don't just be focused on the expansion in terms of population coverage. Be aware that your expansion can be in other ways, and actually some of these other dimensions matter as much as the expansion on the population. Obviously, these dimensions are connected, and often to progress on one, you will have to progress on the other. So this is just to illustrate. This would be a scheme where you have a full population coverage of the country, but where the service coverage is very narrow. For instance, this is a scheme focusing just on tuberculosis and just helping the TB patients, with limited integration, so the things are quite organized in a parallel way, no diffusion outside the health sector, and knowledge which is still limited. Okay, this is purely hypothetical example, and then we will have this second case where here the population's coverage is not as big, because you focus, for instance, on a few provinces, but the package of services is broader. You have, for instance, the full minimum package of activities and the complementary package of activities, so both health centers and hospitals. Okay, in terms of integration, this scheme looks much more integrated in the health system for different reasons. Still here there is no cross-sectoral diffusion, but we see that the knowledge is more advanced. Okay, more people are aware of PBF and know how to operate it, and also the country has accumulated a lot of experience and evidence on this intervention. Okay, so that's the main, our first main idea. Think scale up is a multidimensional progression. This is our second main idea, which is to say that the scale up will be a process occurring in 4 phases. Okay, so these are the 4 phases that we propose and that we have identified from our data and from our own experience. So there would be first a generation phase where you move from idea to project. Then there would be adoption phase, you move from a project to a program. The institutionalization phase, you move from program to policy. And then the expansion phase where you move from policy to system. Okay, so this, why is it so? It is so because to progress in your scale-up, you need to achieve some preconditions, and these preconditions, so they are creating some path dependency, and you will see also that there is a chain of actors contributing to the scale-up, and some actors have a comparative advantage at some time of the process, and they lose their relevance later in the process. So this is the way we organize this progression. And this is what we have observed in the countries we have investigated. So this is not a law. This is certainly not the case. You could imagine countries where maybe the two phases occur at the same time. Still, this is a pattern which emerged from our data. So now I will quickly go through the 4 phases and just present them as a kind of theory, and then later Zubin will present the barriers and the enablers across the 4 phases. So the first phase is this phase of generation. So it's a movement from initial idea to 1 or more pilots. So practically what we have observed in countries is that there is someone, there is a policy broker, a policy entrepreneur coming to the country or coming back to the country and proposing to start PBF, okay, or RBF. So this entrepreneur, he will work. He may be active in an NGO, working with an NGO, an international NGO, sometimes with an agency, and together with the assistance of local partners, there can be a different kind of partners, the government, the Ministry of Health, district teams, and so on. They will develop a pilot project, okay? And this is the end point of this first phase, is the stage where you have a proof of concept. So after 1 year, 6 months, 1 year, 2 years, it depends, you have the evidence that it's feasible to implement your RBF strategy in the country. The phase 2 is the phase of adoption. So you have now this pilot experience, you have a proof of concept, but and there is this decision to go to scale. Okay, this is a phase, it's a quite critical phase, and it's kind of development of a national program. So by national program, we mean a coherent and identifiable set of institutional arrangements organizing the transfer of resources to service providers, which means a kind of a package of contracts, guidelines, tools, and so on. So this is a phase where there is obviously you aim at increasing coverage with administrative units, and you mean to increase the population coverage. So it's a heavy operational stage. This is why you set up a program, actually, because you have to, there is volume. Okay, now it's not about succeeding in 1 or 2 districts, it's about rolling out your scheme on 20, 30, 40 districts maybe. And so it's a huge amount of work, and this needs to be coordinated. So usually what we observe is the setup of task force, national units. There is a development of training materials, training of trainers, a lot of visits and monitoring to the district starting the scheme, adoption of digital tools, and so on. And obviously, as I mentioned, a full package of documents and a manual, guidelines, and so on, contracts are adopted. You have also agreed on some payment formula, and so on. Okay, that's the adoption phase. Many countries are still in this phase 2. Phase 3, this is the phase of institutionalization. Okay, so now you have your national program. Maybe you are not covering the full population yet, but maybe yes, it depends the size of the country. If you're a huge country, probably you start phase 3 when you are still expanding the coverage with the population. If I take, for instance, a country like DRC or Tanzania, they probably start phase 3 before ending really the full population coverage. And there, it's about institutionalization. So you try to transform your program into a national policy. And there, the stake is mainly to integrate your scheme into the 6 building blocks. This is a time where there is a connection, well, the scheme is getting connected with a few things, and a key marker of progress here will be whether you are under public funding or not. Okay, so for instance, at stage 1, this was often, all the stage 1s have been done with aid money, often money coming from international NGOs or bilateral aid agencies. At phase 2, we often see big players coming like the World Bank, but the World Bank obviously can start at phase 1 as well. But here at phase 3, you are looking for integration with the different building blocks, including the finance building block, and a key contribution the main contribution to funding the health system is, of course, the government. So this is a key marker. Is your scheme funded by public money? This is a situation we know which is in place in Rwanda, Burundi, for instance, but which is not yet the case, for instance, in Benin. Okay, in terms, we can imagine, and we have worked on that, but I will not go through that now. For each building block, we can identify interesting markers. For governance, for instance, it's a phase where your PBF RBF scheme is mentioned in major national strategic documents, like governance produced obviously by the Ministry of Health, the strategic plan for the next 5 years from the Ministry of Health, but ideally, your scheme also, your policy is also mentioned in the national, the government policy by the Ministry of Finance, Ministry of Planning, and so on. Okay, so at the end of this phase, your PBF is an integrated provider payment mechanism, and it's integrated really in the health system. Okay, so if I just take, for instance, the building block of information, it would be a stage where there is the data use and the data system used for your RBF scheme is the same than the National Health Information System, for instance. Okay, that's phase 3, and we know that a few countries are in phase 3, and then they may have the chance to move to phase 4. So we call it phase 4 expansion, and this is really a situation where your policy is national, obviously, but is so strong and is so appreciated by the government, by the national leaders, that they start to adopt the principles outside the health sector, or outside at least of the performance-based financing policy. So it would mean, for instance, that there is a recognition by the Ministry of Health that health facility autonomy is needed in the country. Well, it's not always the case, but okay, imagine a country where PBF has been really promoting facility autonomy because there was a major problem at that level, and you enter phase 4 and the government recognized that even beyond PBF, there is a relevance to increase the health facility autonomy, and the government will start to adopt reforms increasing this autonomy. For instance, expanding the rights, the decision rights that the facility managers have on hire and fire for personnel, or the kind of procurement they can carry out, or the fact that they should have bank accounts and so on. So that's just an example. You could imagine also that the principle of separation of functions would also be identified as a key principle, and the principle adopted beyond performance-based financing. Expansion, phase 4 is also an expansion beyond the health sector. Okay, it's a phase where people recognize the relevance of of performance measurement and paying according to performance, and try to apply the same principles outside the health sector. So there is a kind of diffusion of your concepts, principles, doctrine beyond just your PBF policy. So much fewer countries have reached this phase 4. We think that Rwanda has entered this phase 4 and Burundi to some extent, at least before the political crisis that the country is going through. Okay, what is interesting is that it seems that there is a connection between these two main ideas. So I remind the first main idea was to say that scale-up is multidimensional reality taking place on 5 dimensions, and the second idea is that scale-up is a process taking place in 4 phases. So this is not, let's say, rigorous evidence, but I think I will now just show how these two things could connect. Okay, in phase 1, you would have a first pilot starting, and so you start to have some service coverage, you have some population coverage, and you start building some knowledge. Okay, that's the main objective of phase 1 and of the pilot. Then you have the phase 2 when you start your program, and there this is obviously the reason you move to phase 2 is your willingness to cover a larger share of the population, but you may also have at that stage some efforts to integrate better your scheme, which is necessary because your intervention is getting national visibility. Why initially it was just in a few districts, now you get national visibility, so people are talking about your scheme in the central level of the Ministry of Health, and they are raising questions, so you enter this kind of dialogue with a much larger group of stakeholders, and they raise issues, and you have to handle them, and so probably this will push you to have a better integration. And obviously in stage 2, you will expand considerably the knowledge, much more people are informed about the scheme as you expand the population coverage, but also you deepen your knowledge, you produce guidelines, manuals, and so on. Stage 3, it's about institutionalization. This may, for instance, coincide with an expansion of service coverage. Of course, we can continue population coverage, but the connection is not as strict as maybe as well. It could have happened obviously at stage 2 as well. So definitely at phase 3, this is the kind of definition of phase 3. You have a progression on the health system integration. Okay, for instance, I mentioned the fact that you start to be funded with public money. And then we have defined phase 4 mainly as a cross-sectoral diffusion, but obviously you can have still an expansion of knowledge during phase 4, for instance. Okay, that was just an illustration. I will now we will give now the mic to Zubin Schroff, who will continue and present the different enablers and barriers to succeed in this progression of scale-up. And we organize these barriers and enablers across the 4 phases. So Zubin, it's for you now.
Thank you, Bruno. So I'll be presenting the findings from the 10 countries by examining them in each phase, as well as some larger cross-cutting lessons. Could I have the next slide, please? So as we see here, the 11 countries here are at different stages of or different phases. We see countries such as Chad, where the pilot never really went to scale. A pilot was introduced and didn't go further. On the other end, we see Rwanda and Burundi and Armenia as cases. Armenia is not displayed here, as it's outside Africa. Most of these are restricted to, the map is of course of Africa. You can see the Armenia case is one where it's been relatively scaled up, similar to that of Rwanda and Burundi. Could I have the next slide, please? So now I'll describe some of the findings related to each of the phases. So we see here, and this is analyzed according to the policy triangle, the Walton-Gilson policy triangle, which was used as a framing for the country teams to collect their data. So we see that in the first phase, the phase of generation, the schemes, the RBF moved from an idea to a pilot to the coming together of contextual factors, actors, and content. Amongst the contextual factors, we see that there was an interaction of a global agenda in terms of aid effectiveness, development effectiveness, influenced by things such as the Paris Agenda, where there was an increased emphasis on results. This came together with a regional influence, which we see in all the countries in Africa outside Rwanda, of how they were influenced by Rwanda's initial success in PBF. And finally, in cases where countries felt that RBF was something that could solve or help to address a given need. For instance, in Cameroon, there were stagnant indicators where RBF was seen as something that could help to address that. The data from Kenya talks about how RBF was seen as something which could help address health worker shortages. We also heard this from the data from Uganda. We saw the same factor brought out, as well as in Tanzania, where it was seen as a mechanism of addressing an intractable problem in the area of maternal and child health. Another contextual factor which we identified as important was previous expertise with organizational and financing reforms in the health sector. And these include things like voucher schemes and direct cash transfers. Facilities and health systems where people have been used to some kind of different schemes from traditional supply side budget financing going into health facilities, where there has been some kind of innovation what's seen as more fertile for enabling these kind of RBF schemes to initially take root. Amongst the actors, as Bruno described in the phase 1, is a very important role for knowledge brokers or health financing experts who often came in from outside and worked along with an international agency, which was often in the initial phase may have been a small faith-based group or a bilateral or a multilateral in sowing the seed. In the initial phase, we see a greater emphasis for smaller groups, and then later on we see the World Bank, for instance, coming in a number of countries in the next phase. And the fact that this was introduced by a relatively small number of health financing experts who were often known to each other across different settings, when there was a broad agreement on general principles and practices amongst this community of health financing experts. So given that, it's no surprise that we saw that the schemes were not that different across the different settings. And in fact, the Great Lakes model, which was initially brought in Rwanda and Burundi, was really transport was something that became very popular across Africa. And we noticed that funding agencies had an important role in determining focus initially. And this is, of course, because the pilots tended to be largely externally funded with little, if any, national funding. And over time, governments played an increasingly important role. Could I have the next slide, please? Now we come to the next phase, the phase of adoption. And here we see that unlike the first initial phase, national contextual factors become relatively more important. And for instance, pre-existing autonomous institutions and pre-existing structures, health system structures, are also more important than they are for the pilot phase. Examples of this are the regional funds for health promotion in Cameroon, the fact that the state health agency in Armenia also had experience in bringing about health reforms. This was also another important enabler in Armenia, coupled with enabling legal frameworks and changes. These are the kind of frameworks where facilities were given autonomy to handle cash. This is an important legal change. Facility bank accounts are another important enabler at this stage. These sort of contextual factors become increasingly important as you move to phase 2, and you move from a pilot to a larger scale, where you need to have these kind of enablers which allow for this to happen. The second important contextual factor we noticed in this phase was that RBF schemes were able to scale up where there was a national agenda which was matching that global agenda. So the national agenda, especially that of transparency and results, really did help to hasten the process. And the two countries where we really see this are Cameroon and Rwanda, where in Cameroon there's a great emphasis on addressing corruption, and in Rwanda there's a great emphasis on results. And both these help to hasten the scale up of RBF programs. Amongst the actors, we see that international agencies continue to be important, as they were in the pilot phase, so probably less important than they were in the pilot phase as national actors get more important. They provide funding and technical assistance, though unlike what was often seen in the initial pilots, like many countries you see a large number of agencies implementing their own pilots. In the second phase, what you often see is one agency taking a dominant role. And we see this in Rwanda, in Cameroon, in Kenya, in Armenia, in where you have in the first three, you have the bank taking an important role. In Armenia, it's very much USAID, which has a very important role. And the international agency takes this dominant role and has to drive the process forward. But there is also a very important role for national policy entrepreneurs. And these could be individuals from the Ministry of Health or those who worked on the pilot program. There may be people from the Ministry of Health who worked in the pilot program who then work with the international agency and engage the MOH in driving the process forward. And at the end of this phase, you see it's associated with the development of a critical mass of national level practitioners who are well versed in RBF principles, in the implementation, in the problems that can arise in implementation. And especially, we know the Cameroon study brought out the importance of having regular training courses in actually creating this critical mass of national level practitioners. And here we see an important process which is brought about by the actors taking advantage of the context, which is the role of coordination and aligning stakeholders. So we see both the single international agency take charge, involvement from policy entrepreneurs from the MOH or pilot programs who help to bring all these, align the stakeholders and help push this forward, often through setting up a task force, which then helps to actually design the program. Coming to the next phase of institutionalization, an important point to note here is a high level of continuity between the phase of adoption and institutionalization. But it's not something, and while there are features of path dependency, which Bruno mentioned, it's important to note that this still needs a lot of active management. Amongst the contextual factors, legal frameworks continue to evolve. You have to actively make changes to enable the RBF principles to really get integrated into the regular functioning of the health system. For instance, in Armenia, you see that there is a sequential introduction of legal changes which allow open enrollment, allow for facilities to take pay for performance measures. Similarly, in Cameroon, you have legal frameworks which continue to evolve and allow for transition of RFHPs and allow them to receive public funds. These are different kinds of transitions which happen over time, which are important to actually enable the institutionalization to take place. And a lot of this is enabled by increased security of funding, especially from domestic sources, showing national ownership. The domestic financing increases over time, and this is seen in a large number of countries. Amongst the actors, in continuation of the previous phase, you see increasing political and technical leadership of the MOH and national RBF experts. What's important here is leadership goes beyond the Ministry of Health, and the national ownership, goes beyond the Ministry of Health. And this is important for actually getting buy-in in terms of financing, especially from the Ministry of Finance, from Social Security agencies, from local governments, and other stakeholders within national systems who are important in actually establishing RBF and RBF-like mechanisms as integral parts of the health system architecture in country. And amongst the content factors, you see, again, progressively greater country-level influence on design, reflecting, again, the greater domestic resources and national ownership, as well as technical leadership, which has come as a result of the critical mass of practitioners developed in the previous phase. So we see this in Cambodia, where we see a gradual movement in different forms of contracting, to forms of contracting with greater involvement of the government and less involvement, direct involvement of the international agencies and international NGOs. We see this in Rwanda in the design and implementation of the community PBF scheme. And in phase 4, we see that knowledge on integration health informs attempts to extend PBF to other sectors. and that is already Bruno has described that. Amongst the actors, in addition to national level expertise, there is high level political support to take PBF principles forward in sectors beyond the sector where it initially took place. So you look at, for instance, mayoral contracts in Rwanda, it extends to the education sector, and actors are high level political actors are very fundamental to enabling this to happen. Amongst the content factors, you have variations in developing these principles to other sectors. So basically the combination of high level political influence and knowledge in underlying principles, which is very well developed by this phase, allows you to extend PBF principles to sectors beyond where they are initially implemented. This was a broad overview of the factors identified from our data on the kinds of enablers at each phase. The contextual enablers, the content enablers, the actors, and the processes. Now I'll describe our broader lessons we learned from our study. So the first lesson we have is some countries stay stuck in phase 1 and remain at the pilot phase. The second lesson is that rhetoric and framing of the issues matter. The third is describes the chain of actors that scale up requires. Again, getting back to the point that scale up is far beyond just increasing population coverage or increasing the number of facilities or the range of services. But there are underlying incentives that are different at each stage of scale up, which requires the chain of actors involved who are different, and this requires very careful management. The fourth lesson is to look beyond the label of for the content when you're examining interactions between RBF and other health system reforms. And the fifth is to balance what is technically best in terms of an RBF program against what is politically feasible. I'll describe these each one in greater detail. So coming to the first lesson, we noticed that a number of countries don't manage to move beyond a pilot. And there are a number of factors that are important here. First is understanding how a pilot is framed. Is a pilot framed as a disease-focused intervention? It is framed as a trial of something that can only cater to a particular disease, or is a pilot framed as a larger health system strengthening intervention? And we see this difference between Mozambique and Cameroon, where in Mozambique we have a RBF program introduced as largely addressing HIV, and therefore it was framed as where most of the indicators was focused on HIV. It was then perceived as an HIV intervention, and that allowed it to be labeled as such. On the other hand, in Cameroon, we noticed that the RBF intervention was really framed as a health system strengthening intervention, which was important in enabling its take-up by national policy and decision makers and driving it forward as a very central part of overall larger health reform of the primary care system. Linked to this is who implements it. Again, if an entity is largely focused on a single disease, the RBF program, the implementing entity is focused on a single disease, the RBF program will be seen as a single disease intervention. It's another part of the important factor amongst who implements it is the implementing agency's political, technical, and financial influence. Now, again, you see in Cameroon, you have an agency such as the World Bank driving the agenda forward, taking on leadership for taking RBF forward. Similarly, in Armenia, you had the government very much involved, but there was USAID really pushing this forward as part of its larger primary healthcare reform. Another factor that is important is which level of government is engaged. And this is very interesting that in a large number of settings, RBF programs have engaged at the district or provincial level initially. And this is great for initial rapid uptake because it's seen as there are often less rules to be got around. It's seen as an urgent problem, the problems of lack of health workers, which in RBF seems to help to address. So you often have enthusiastic responses from lower levels of government to take up these programs. But only engaging at the district and provincial level has a potential pitfall at a later level, at the national level. And then to scale it up at that level may be difficult because the incentive structures that are there for provincial and national governments may be quite different. And we saw this in Mozambique, where it was scaled up rapidly within provinces, but to take it from province to into provinces, but to take the scheme from province to national level became difficult. And similarly in Uganda, where this was largely done at the district level, and there it became very difficult to take it to the national level because national level policymakers hadn't been engaged from the start and saw this as something that was not really, which was something that they owned or were engaged with right from the start. Similarly, is it largely implemented within the public system or outside the public system? You see this in Uganda, where RBF was taken up by the not-for-profit sector as a way of, it was supplemented funds. It didn't contradict the service rules the way it contradicted service rules in the public system, so it was implemented outside the public system. But then when it came to being implemented within the public system, it faced a number of barriers, and therefore scale-up was difficult. And finally, more pilots are not always better. While more pilots reflect more learning, but more pilots can also reflect the fact that there is a lack of stewardship and coordination going on at the level of the Ministry of Health. And this is seen in the Uganda case, where until recently there was quite a gridlock or deadlock, so to speak, in moving forward with scaling up RBF. There were a large number of schemes, but not one of them had managed to actually break through and be scaled up. The second lesson is that rhetoric and framing matter, and RBF programs, especially at the initially at the international level, are put forth as transparency enhancing, part of a results agenda. And while this works in settings where there is an appetite for a results agenda and it fits in with a national mood for transparency, this may not always be the case. And its potential to directly confront interests which are keen on status quo can actually retard the scheme. And therefore, you need to carefully analyze the political situation to see if this is the most appropriate strategy. And is it really always the best to sell RBF in the same way in different settings, or does this need careful tailoring according to the setting where to make it fit the local setting better? And this is something that people interested in scaling up need to carefully consider before they make their case and how they pitch their case. The third lesson we see is the scale-up needs a chain of actors. And here we've seen up till now how the dominant actor varied by stage. For instance, we see the initial experts, the health financing experts from outside, who are the dominant actors at the phase 1. You have officials from the MOH being important in phase 2. The Ministry of Finance becomes a very important player in phase 3. And so we see how each actor controls a key resource for a particular phase. So what lessons does this offer? First, there's an important lesson in building a support coalition and anticipating who is important for that coalition well in advance of actually engaging them. And you need to actually identify the stakeholders who are important and work on understanding the underlying interest of each of these groups right from the start, because as stakeholders change, so do their incentives, and this links back to the point I made about the difference between provincial and national level governments. So the incentives for provincial level governments may be completely different from national level governments. For instance, for a provincial government, selling PBF as something that can address health worker shortages if they are directly implementing and the primary care system, it's far more appealing to them. They may not look so much at long-term national sustainability at that stage, but as you get to the national level, questions of sustainability will come up, and you have to think of these sort of issues much more at a later stage. Could I have the next slide? The fourth, lesson 4, please. The fourth lesson is to look beyond the label and the content of other reforms. And this is an interesting case from Kenya. We've always, generally, RBF programs, we talk about increased autonomy and decentralization being good, but you have to carefully see what is being decentralized, who is getting autonomy, and what they're doing with this autonomy. So decentralization and autonomy can enable our PBF programs a number of ways, but can also alter who does what and what the incentives are for different players. And we see in Kenya that devolution increased accountability and took decision making closer to people, but it increased the chance of reduced spending on public goods and more spending on things like infrastructure. So you have to carefully actually see what the content of reform is rather than the label in understanding how RBF will or will not interact with other reforms within the health system. And the final lesson that I'd like to talk about is to balance the technically best RBF program against what is politically feasible. And as scientists, we will almost always argue for the technically most optimal intervention to be introduced in a given setting. But it's important when you're looking at implementation to see how likely a program is to be implemented before making a decision. So my message here is that a technically suboptimal intervention may sometimes be the right choice when weighed against increased government buy-in. And the chance of long-term sustainability. This was example was there in Cambodia, and the international agencies were quite keen on models which involved greater involvement for international NGOs, were probably more expensive because they'd shown better results objectively in a initial pilot. On the other hand, the government wanted greater control and chose a model of contracting that was technically suboptimal and not necessarily going to give as good results at the initial period of time, but was something in the long run that enabled government buy-in, which is only something that's very important when you look towards long-term scale-up. So there's an important need to look at the trade-off between these two when taking these decisions. So that's it from me. Thank you.
Thanks a lot, Zubin. So this is Bruno again. So it's around 3 p.m. So now we are about to start the question and answers. So there are two models. You can either wave your hand through the technology, or you write a question, and then the question will be transferred by Joel to myself or to Zubin. So please go ahead, and if you raise the hand, we will try to give you the microphone so you can be able to talk. Otherwise, just write. It's fine as well.
Okay, Bruno, Zubin, I think Sophie asked a question about what do we see as a key research question to pursue moving ahead, following from your finding here. So I think Zubin can answer this question.
Could you repeat the question, please, Joel?
The question is that what do you see as key research questions to pursue moving ahead?
As key research
following
questions?
on from your finding here.
Okay. If you ask me, can you hear me, Joel?
It's very good. Go ahead, Zubin. Go ahead.
Okay. So there are two questions to me which I think are most interesting going ahead from the current state in which RBF is in, and I think one of them is the interaction between RBF programs and national insurance programs that are increasingly being introduced, and how do you actually design these interactions going ahead, moving towards UHC. And my second question, which I think I've raised before in a number of fora, is the importance of trying to analyze what is the long-term effect of RBF fee-for-service, especially given that a lot of the schemes in Africa have tended to put much higher percentages of their overall provider payments through incentives rather than in high-income countries which have used pay-for-performance measures, and what are the kinds of implications of this on long-term cost escalation and utilization both, and our need to balance these two in the long term. While in the short term, we may be looking at increasing utilization as our main indicators, especially for primary healthcare and low-cost services. What can this do in terms of setting up perverse incentives in the long run?
Okay, so myself, I will try also to answer this question. So if I can summarize with the 3 phases, we have phase 1 is a phase of design. The main challenge is to get a good design. Phase 2 is really a phase, the challenge is operational, where you really have to bring volume. And phase 3 is the phase of complexity, where you have to integrate, you go beyond your scheme. So actually, from phase 1 today, I think we have a robust design, which is enough to start something. We know, I think there is a body of knowledge which helps country to go to volume, to go to program. I think the challenge is the many questions remain at phase 3. How you handle this complexity? How do you merge your scheme with within a national healthcare financing strategy? How do you improve quality of care, service delivery with your scheme? So when I mentioned this robust design is good to start, but it needs to be updated. And we know today, and those of you who were in Dar es Salaam in November or October 2015, remember, we know that we have to update PBF to handle better quality of care. We know that PBF is not the magic bullet for quality of care, that there are many other interventions which remain very relevant and important, but we believe that PBF can contribute. And so what we achieve with quality of care with the robust design is what we could achieve with such a robust design. So now we have to update and sophisticate and revise some of our hypotheses. So I think there is quite some work on theory of change, actually, and I'm happy that some young researchers are working on that. And definitely on how we should better address quality of care. So yes, I think the questions are on phase 3.
Okay, we have another question by Felix Abraham Obis. How might subnational governments in countries like Nigeria going through recession be able to adopt and scale up RBF, or would it be better for them to consider non-financial incentives and in-kind rewards? And what are these sort of incentives being piloted? I think, Bruno, you can answer this question.
Joel, can you make sure that you send me also the question, because it's easier to read them sometimes than to listen to you. But I understand that it's a question coming from Felix from Nigeria and about scaling up in Nigeria. I would just say first, and I'm not sure that I will answer the question, but most of the countries we've studied are small countries. Okay, we have the exception with Tanzania, but most of the other countries are not huge countries like Nigeria, DRC, or well. So I believe that scale up in big countries, federal countries, is a different story. For instance, if the country is really big, to have a pilot in a province may not be enough to convince the government, or well, if the province is very far, if you have a pilot in South Kivu, I'm not sure it will influence Kinshasa. So and that's possibly we can have similar situation in other big countries. So I must say that we have to be cautious how we extrapolate our findings to big countries, but definitely, well, we have the experience of China as well, where there have been a push for pay for performance in a few years ago, and then there was a multiplication of innovations in many counties and provinces. But at some stage or so, there were too many pilots, as mentioned, Zubin, and there it may be an issue in terms of harmonizing and bringing coherence. So that would be a specific concern for big countries, would be how do you manage the numerous pilots. Then it's probably about organizing very good knowledge management. Maybe you have to set up a committee of practice for Nigeria to make sure that you connect all the knowledge holders, a hub, as they have done in DRC. They have set up a hub committee of practice. Another issue for huge countries definitely is population coverage, means a lot of money. And this is already the case in Tanzania, in DRC, and I'm sure in Nigeria. So the time also that you will take for your scale-up is probably longer. So Rwanda and Burundi were able to move really fast, Benin as well. You just have to convince a few partners to have a population coverage, while for huge countries like Nigeria, you have to obviously to involve the different states, and this will take time, plus the national government. So I don't know if I fully answered the question. Joël, is it okay or? I see many questions coming now. Joël, do we have a sequence? Or we may have lost Joël. Okay, I see other questions coming, so I will take a few and try to give also some to Zubin. There is a question: is your experience in expanding the number of indicators from maternal and child health to the whole health, or maybe to HIV, TB, and malaria to start with? So this is a question about the sequence of scaling up in terms of service. So you remember the second dimension of service coverage, and there you can imagine a different. So what we have observed that starting just from HIV/AIDS and then moving to other services seems not working. Okay, we have the case of Mozambique, where they started a scheme focusing on HIV/AIDS. It was with PEPFAR money, and then they didn't develop the chain of the coalition of actors to move outside the HIV/AIDS. So I saw that Joanna Falcao was on the panel in this session. She may want to complete what I said. I know that there was also such a process in Côte d'Ivoire 10 years ago, and I saw Noel is also on the session, so we could discuss this. But my feeling is it's not a good idea to start from a narrow perspective and then try to expand the coverage. You probably have to start with starting with maternal and child health seems a very good basis. Many countries manage to start from there, and actually could be interesting not to include from the beginning all the diseases, because if you keep some diseases outside, these are programs you can discuss with at a later stage. Okay, if you don't have HIV/AIDS in your pilot, but when you want to move to phase 2, there you really need money, and it's interesting then to include HIV/AIDS, malaria, and TB, and then approach the Global Fund. Okay, that's a model which seems to work in a few countries. So bring more indicators at a later stage in order to bring more money. And some of these vertical programs, they are not willing to pilot things actually. So the Global Fund will not be interested in phase 1 so much, because this is not their practice or their focus. They are more for scale, and so they'll be quite keen on coming to phase 2 in phase 2 actually. So this would be my view, but it's not exclusively based on our research, I must say. That's a bit broader observation. Maybe, Zubin, a question for you.
Yeah.
A question coming from Colombia.
Yeah.
And this is the question, I don't know if you saw this question. At which of your phase do you start switching the mentality of local stakeholders to pay for outcomes rather than outputs? How does this change scale up? This has been a big challenge when working in contexts where results are already paid for, but outcomes are not necessarily achieved. And you talked about that, Zubin.
No, could you just, do you have it in writing at all? It's a rather long question.
Yes, okay. Joel, can you send this question also to Zubin? I will try to answer already a bit to Alessandro. So that's a very good question. And I think it's coming also probably at phase 3. So keep in mind that many of these countries, the countries we have documented, these are countries where there was no output-based payment from the government before. Okay, there were output-based payment for curative services by the users, the user fees, but all the money from aid, the donors, and coming from the government was a kind of input-based funding, okay, payment of salaries, per diem, equipment, and so on. And so for these countries, moving to output-based payment like performance-based financing, it's a huge transformation, okay? And now we realize that indeed, it's not because you pay for output that you get outcome, okay? We have not much evidence on that, but we have evidence to be very cautious. We know that in PBF managed to increase coverage rates in several places, not for all services, but for enough to be confident that we increase coverage rates. But we have questions more and more about the improvement of quality. There is improvement of quality, but we are not sure that the improvement of quality is the kind of improvement which will improve outcome. Okay, so so there is a question: how can we make sure that we improve outcome? And most of the countries that we have documented are not yet in this outcome logic. So I agree with you that it's challenging but we hope that countries will. It's their policy now. Okay, many countries are in phase 2 or phase 3, and these are phases where you start to question yourselves. Okay, you have adopted the concept and you are kind of converted to this new model. And then a key principle that we try to promote in the PBF community is improvement and learning and improvement. And this webinar is an illustration of this commitment to learning. And so we hope that countries will be keen on improving their strategy and move to new kind of indicators, including sometimes when it's possible. It's not possible with every disease or health problems, but for a few it's possible to integrate outcome measurements. We hope that some countries will move to outcome. So my answer would be this will take time, and this is you probably have to be in phase 3 to be in a position to acknowledge that you have to update your policy. Now I could imagine then some pilots from the start have a design where they measure some outcome. This is obviously possible as well, but this is not so much the story so far. Countries prefer to move to a robust and basic design.
Bruno?
Yes, please.
Yeah, so there are both these questions. First is about the outcomes and outputs. I think this is also linked to your payment systems to a great extent, right? If you can move to a system where you actually are able to hold providers fully to account for a given population, it's easier to have an outcome-based system than an output-based system, which of course can be purely on process measures or largely on process measures. So I think that's another thing which needs to be on the kinds of systems that you need to put into place to actually ensure that that there is a certain catchment area which is actually adhered to itself. It makes it much more difficult to actually implement an outcome-based system rather than an output-based system. How do you hold people accountable for a given population? So I think that's an important factor there. And in the next question of national policy entrepreneurs, the next question says, for phase 2, you speak of national policy entrepreneurs coming from the MOH or pilot programs. Then in phase 3, you mentioned leadership of MOH and national RBF experts. Are these RBF and national RBF experts the same that were involved in pilots? They may or may not be the same people who are involved in pilots. And you may have some of them. So the main thing about in phase the end of phase 2 and early phase 3 is the critical mass expands of national RBF experts, but you may have national RBF experts involved in phase 1, but often taking a position where they are the local or the in-country knowledge brokers to the policy entrepreneurs from outside in phase 1 who are the health financing experts. That's my explanation of it.
Thank you, Zabil. So there is then a question, a quite early question from Paula. You didn't mention cost of verification, which can be substantial. Any lesson about how best to manage this in context of scaling up and institutionalizing PBF? So Paula, thanks a lot for this question. It's a very relevant question. I fully agree. We have not studied that in this research, so it was more trying to understand the enablers and barriers for scaling up. But obviously, cost can be a barrier. That's clear. But let's say that cost of verification is identified by stakeholders, by several stakeholders as an issue. We fully agree. Even by the PBF people, we are aware that it can be very expensive. I can take the case, for instance, of Benin, where the verification system is indeed very expensive, and one donor said that that's too expensive. So they are now pushing for reducing the cost, and you may have seen on the Committee of Practice website there are blog posts. There is a blog post on cost of verification, and Benin is trying to take lesson. And so there will be a blog next week or in 2 weeks about verification in Zimbabwe by Eric Josephson. So with the Committee of Practice, we want to work on that. That's the first point. And so yes, I agree that there is an issue of scaling up and a relationship with an issue there. And for instance, what we observe is you can have path dependency, where in your design, your pilot phase, you invest massively in verification because you want to create trust and you want to have this convincing proof of concept. And then you scale that up in the program phase, and then you hire a lot of verifiers, and then they become stakeholders by themselves, and then they expect to be institutionalized in the solution. Why this is probably too costly. So you may have to change their profile, to downsize the verification team, and there you may have to fight with your own bureaucracy. So I think there is an issue for PBF programs, not to create a massive bureaucracy, otherwise you probably stuck for the next phases and you have a too costly model. So we have to work on that. The PBF committee should be aware of this need, so we hope that we will take this on board in 2017 as a key learning agenda. So please join with your ideas and propositions, but I fully agree that that's an issue. There is a similar question coming from Jeffrey. We are seeing increased pressure on achieving efficiency and cost effectiveness. Our data and yours suggest that the pilots, which might be better termed demonstration projects, are not cost effective. So politically, what do you see as the key questions approach to address this? That's a bit what I just said. So we have to, I think we have to work on that as a community. We should not, let's say, hide this issue. We should not try to deny it. There is an issue of cost effectiveness. There is an issue of keeping transaction costs limited. In these 11 countries, there are interesting case studies. One of them is the one from Cameroon, and we will organize another webinar on that experience of Cameroon. Isidore Cielelou, the principal investigator, studied another question. It was, how do you organize a transfer from an international aid agency or consulting company like IDES or Cordet to the national authorities? So this is qualitative research. It shows that there are indeed barriers and enablers to succeed this transfer, but it's clear that this transfer has different objectives. One is country ownership, but also it's about reducing the transaction costs. So to have less technical assistance and so on. So we have to work all of us on that, because it's definitely a weakness of the strategy when we go to scale.
Bruno, can I interject on this?
Yes, of course.
I think there's an important question here to be asked of what we really want to achieve from pilots, given that a wealth of experience has already been gained. I mean, and what are you trying to work on? Very exact effect sizes, which is what probably makes the pilots to the cost ineffective or cost not efficient as you do, or are you using them to understand how to implement these schemes in settings and then looking more at these larger questions of institutional transfer and mechanisms of actually effectively implementing a program. So it depends on how you're going to frame the pilot's actual use to inform a national program. Do you need that level of effect-sized exactness, which is what takes up sample sizes, or do you need to see of how to use a pilot to actually implement a program?
Yes, thanks, Zubin. And indeed, Joe Christine made a quite similar point recently. So it's, of course, he's upset also about sustainability of all these PBF programs. And he said, well, what we need is really the mechanism. So all these countries have to move to strategic purchasing. So this development is a very good development. Now, do we need, well, first question, do we really need so many impact evaluation? But more fundamentally, maybe we have to put less money, and because that's the mechanism is maybe more important than as Zubin was mentioning, really this impact at short term. So there it depends a bit on the priorities, I would say. Okay, then there is a comment about a question coming from Corinne Grenger about successful move from district to national level. So, and she refers to Malawi, where the things are maybe not easy. Well, they are, definitely. That's the case, the story of Rwanda and Burundi, for sure. I think there is a very strong dynamic going on in DRC for the moment. So the story of Tanzania is a bit about that as well. So, well, I don't have recipe, but this is not, it seems to us that it's not the main problem. It is also the story of Cambodia. There were a few pilots, and then as we can just mention as Zubin said, that sometimes you have to adapt the scheme to when you move from the district design to the national design to make it simpler and accept that things change a bit. But we think that this transition from local to national is not a major problem. Okay, we still try to review questions. For phase 2, you speak of national policy entrepreneurs coming from the MOH of pilot programs. Then, when describing phase 3, you mentioned leadership of MOH national RBF experts. Are these national RBF experts the same that were involved in pilots? So, Zubin, you want to say something about it?
I've already discussed this question.
Okay. Okay, can we, maybe some persons want to talk as well? Valérie or Maxime, are there some hands or? Joanna, I don't know, is Joanna still there? Joanna, do you want to contribute on moving from HIV/AIDS to other indicators? I don't see Joanna anymore. Anyone willing to say something? Raise the hand. Okay, then Uzoman Wankwo, you want to say something? Can we give the mic to Uzoman Wankwo? Uzoma, you can speak, please.
Hi. Yes, thank you.
Hi.
Thank you very much for. Yes, how are you? I'm speaking from Nigeria, and thank you very much for the very interesting webinar. I have a question I'd like to get your opinion on. So I'll just give you a background of your own comments around trying to so you talked about targeting RBF so that you're speaking to a wider, broader health system issue as opposed to focusing on disease, something a little bit more disease specific, because then it becomes difficult to scale up. So if you look at the structure of RBF and the need to have indicators that you have to verify before incentives are reimbursed or paid, those indicators a lot of times speak to specific disease areas. So I wonder what you mean when you talk about framing RBFs in the context of larger health system issues. I'd like you to maybe shed a few more light on that. I know you've talked about maternal and child health issues. That in itself has specific components. If it's in terms of a number of children vaccinated in a facility, if it's in terms of number of women who have access to antenatal care, that in itself you're actually speaking to specific areas. That's one. And then I want to ask you, and this is for my own consumption, are there examples of use of RBF-styled mechanisms for outreach interventions? Now, literature shows that RBF mechanisms are best used for facility-based interventions, but I tend to think and believe that certain interventions are not based in facilities, but are actually outreach, community-based interventions. Are there studies, has there been any work on such interventions that are focused on, improving, measuring results with outreach interventions?
So
those are my comments.
Thank you for your question. So quickly on the second, there are some schemes, they are called community performance-based financing. So these are schemes targeting, let's say, community health workers. So there is the first country to start that was Rwanda, and Rwanda actually is part of our study, and we have a documentation of the scale-up of this community-based scheme. And there are a few more starting now in Africa of this. So yes, but the knowledge is still, the evidence is still limited, and so it's still under construction. On the first question, the point is to say that, when we started PBF, we could have tried to sell it to the Global Fund and to PEPFAR. We could have said, oh, we have invented something which is very powerful. Let's put a lot of HIV/AIDS money. But this is the people who designed the strategy in Rwanda and so on were mostly health system people, not disease-specific people. And all of us, we were very upset of the risk that this solution would be taken over by vertical program. So from the beginning, the framing has been, this should be focused on should cover the full minimum package of activities in first line and should cover the full complementary package of activities at district hospitals. And so I think that the experience is that this way of framing helps a lot for buy-in from the Ministry of Health, but may of course affect the buy-in from vertical programs. So I would say that as a strategy for scale-up, that was probably a good strategy, especially that the World Bank and the trust fund organized by the World Bank is on maternal and child health. So this approach to cover the minimum package of activity fits really well their focus. So but we observe in some countries that it's not always easy to get the program contributing to the PBF scheme, and one reason is because this funding from the Global Fund, for instance, may be captured by some actors, and they are quite reluctant to lose these resources. So the Global Fund is contributing in some countries, like Benin, DRC, for instance, but we see also that in other countries, this discussion does not start, and it's not so much because of the Global Fund, it's more because of those actors already benefiting from the Global Fund assistance. And I don't mean that what they do is irrelevant. Maybe it's right, the fact that they continue to finance what has been done so far. So that would be my comment on that. And as I mentioned before, starting from the maternal and child health gives you still the opportunity to approach vertical program later, but that's not, as I just explained, that's not always effective. So that would be my answer to your question.
Thank you very much.
You're welcome. Alejandro, Alejandro would like to talk, so let's give the phone to Alessandro. Go ahead.
Hello.
Hello, Alessandro.
Hello. Can everyone hear me?
We hear you very well.
Okay, good. Well, it's very interesting webinar. Thank you very much. Yeah, I mean, I wanted to ask further down the line on the question on how you have observed in these countries, especially knowing the case of Rwanda, on how health has actually permeated into other sectors. So, for example, we know here about the program the World Bank has in agriculture and payment for results. How did that transition happen? Are you aware of like the generalities or like which stakeholders led the system? Like, was this something that the health ministry then passed on to the Ministry of Finance and then to the Ministry of Agriculture, or did the synergies like happen in some other direction?
Thank you for the question. I can answer that, but Zubin, do you want to say anything first?
No, Bruno, I think that's a question I'd prefer you to answer.
Okay. If anyone in the session is from Rwanda, he may also complete. What I know about Rwanda is that when the scheme started in nearly 10 years ago, 10 years ago there were discussions and we had the first findings from the very first pilot. And these findings were presented, well, in Rwanda, at that time, I guess it's still existing, the president was organizing a retreat, I think 2 retreats per year, where all the key managers of the government, the ministers, their chief of cabinet and the general secretariat, but also the province directors, they were gathering and they were reviewing progress with development. And in one of these retreats, the experience of PBF was presented by the people from health, but together with the provincial directors. And this presentation was, well, many participants were impressed and participants also from other sectors. So I would say the first mechanism, obviously, for other sectors to adopt the idea is that there is a good knowledge management, a good sharing between the different sectors. And what was important as well is that the president of Rwanda was really developing a very strong leadership in terms of development and sending very strong signals to all the technocrats that they had to innovate, to come with new ideas, to boost performance of the social sectors and so on. So there was a general culture in the government to try new things, and new public management style approach were very popular, let's say, and welcome. So that would be my main observation from Rwanda, the importance of working with reformers and connecting these reformers, making sure that they are aware of what's going on outside their sectors, and having a very good knowledge management. And then there were other mechanisms, but probably more internal to the government and to the party in power, and on that I know much less. But this is the anecdote I've been told, and it's by several key informants. So we have, this is really triangulated.
Okay, thank you so much.
Any other question by written or someone raising their hand? Let's check. Okay. Laura Gauthier, you have a question. Do you want to take the mic? Lara, est-ce que tu m'entends?
Thank you, Emma. I have no further questions. Thank you.
Okay, you don't have any question. Okay.
I have a question.
Okay, go ahead.
Thank you. Oh, so I just wanted to find out when we describe, I'm sorry I missed the very beginning parts of scaling of the PBF, but just contextually, when we talk about PBF, are we referring to all of the subsets of the different result-based financing mechanisms, called different terms, from performance-based contracting, performance-based pay, output-based aid, conditional cash transfers, and is this the examples and the country experiences that you describe? Does it cut across all of this, or is it?
Okay, I understood your question, so I can answer it. So no, this research was indeed on results-based financing, and under results-based financing we include a lot of different kind of schemes. Okay, vouchers is a RBF, health equity fund is a RBF, conditional cash transfer is a RBF. Performance, actually, on all the country teams submitted propositions on performance-based financing schemes. Performance-based financing are RBF schemes which focus, the incentive package is focusing on the health facilities. Okay, so it's more kind of, some people call them supply side mechanism. So it's paying facilities for improved performance. And most of the cases were really the kind of what we call sometimes the Great Lakes model, so very similar to the design implemented in Rwanda and Burundi 15 years ago, so 10 years ago. So it's no, we are talking more here about performance-based financing schemes, so schemes focusing on health facilities. Okay, we are about to end. I'm just checking if there are still Ariane, you still have a question? Do you want to tell it? Ariane, the mic is for you.
Oh, thank you. Yeah, not really a question, but maybe just to highlight or to tell a bit about the Zimbabwean experience. Although I see I have a Zimbabwean colleague in the meeting, and Mr. Mudzimo, he might be better positioned to explain it. But an important lesson, I think, is that the pilot started in all 8 provinces. So whereas from an implementer's point of view, that was quite a challenge, it facilitated the rollout, because all the provincial medical directorates were sensitized and involved, and yeah, so that helped to scale up. The pilot took only 2 years, and then the government decided that it was a useful intervention. So it only took 2 years to before the country started working on a national scale up, and that was a challenge for the other implementer, who had to start RBS in 42 districts in one go, but they managed. And we're currently in the process of discussing the handing over to the Ministry of Health and the modalities. Verification has started already, so that is one task that the Ministry of Health is taking up. for accountability, we are thinking about organizing peer verifications, and then so an element of external verification needs to be maintained to have accountability. So I see Sophie is also on the list of participants, and she's making recommendations on how this can be done efficiently. But yeah, just to highlight, and I think we need to also explain our verification model. That was a full verification in the beginning, and that's when we saw there were very little errors. That developed into what we call a lighter verification model, or a risk-based verification model. We'll soon hope to explain in the forum a bit more about it. It made it really light and not cheap, but much cheaper than in the beginning. So there are a few interesting lessons from Zimbabwe that I wanted to highlight to the participants. Thank you.
Thanks a lot, Ariane. So yes, that's important indeed. It's good to know that there are different tricks to convince the national government to move to the national coverage. But indeed, the more provinces you involve, the greater the critical mass of supporters if the strategy works well. Sometimes it's better to have to do your pilot in a limited number, for instance, not too far from the capital city. So there are different strategies, and it seems that in most countries those in charge of the pilots understand these strategies. Even if, as it was mentioned by Zubin, in a few cases we have situations where the country is stuck in phase 1. So there are questions there. This problem of being stuck at phase 1 will be covered in another webinar, and the speaker will be Joël Arthur Kende-Braogo, who will present the case of Chad. And so we hope that you will be many for this other webinar. As I mentioned, there will be a webinar about succeeding the transition from 8 partners to national entity, just as it was mentioned now by Ariane in Zimbabwe. We believe that many countries also are interested in this kind of question. So definitely we want to learn much more from all countries. So we have done these case studies, and so we will continue to do work on that. So there will be blog posts coming. There will be working groups also set up. There is a working group on verification which is about to start. All of you will be informed about that through the community of practice. So we have also produced policy briefs from this research. So the policy briefs will be released in the coming weeks. And so we hope that we will stay in touch with all of you. This PowerPoint will also be available through SlideShare or through other means. So I think we are reaching the end of the session. I don't know if, Zubin, do you want to say still anything?
Sure. We have a question from Uzoba about the work being published. I think we should also mention the fact that we have a journal supplement coming out in the journal Health Systems and Reform in April. And we will then, this will be of course widely disseminated on the to all of you.
Thanks a lot, Zubin. So thanks again to the Alliance for Health Policy and System Research to have funded this research program, which is a fascinating research program. And thanks again to the Norwegian government to have funded this research. So thanks to Joël and Nadej to have organized this webinar. Thanks to Valérie and Maxime for the technology and Annelies. So I propose that we end here. It's Friday, the end of the week. Thanks to all of you, and so we keep in touch. Thanks for your many relevant questions. What is fascinating with this interaction, that you open our eyes on new questions, and it's always very helpful also for us. And this is still work in progress, so we will definitely take some of your comments and reflections for our papers and reports. So thanks a lot, have a nice weekend, and bye-bye.